Okay, Sam. Okay, let's go, Sam. Let's go start.
Okay. Bismillah. 63 years old man with a history of heavy smoking presents with cramping pain of the left hip and buttocks. On examination, he has a palpable right femoral pulse, but it is non-palpable on the left. The left foot appears normal. The level of arterial occlusive disease is most likely the left iliac. The options: superficial femoral artery. This is wrong because according to the presentation, it will be aortoiliac disease. B, popliteal artery, also it's wrong. Anterior tibial artery, no. Common iliac artery, yes. Common femoral artery, no.
Yeah,
It could be combined, but mainly iliac artery, yes. Common iliac artery.
Okay, because no, you know.
So, okay. Yeah.
An easy one. About time. Let's go to the next one, Sam. It's easy. Go on next one.
Okay.
Let me see.
Symptoms most predictive of vasculogenic claudication rather than neurogenic intermittent claudication, which is pseudo claudication, include. Okay. So we are talking about the symptoms suggestive of neurogenic, of vasculogenic.
Yeah, which one you can tell, because this is very common. I mean, always they come to the clinic, they'll have legs pain. You have to tell, is that from sciatic nerve compression or is this a vascular? This is very common scenario. You see it every day. So let's say one by one. What's the first one?
Okay. A, pain relief with cessation of ambulation. Yeah, this is can be both neurogenic and vasculogenic.
There's some. Why both? This is typical vascular, right?
Yeah, but rest, yeah, but both will relieve by rest, cessation of ambulation.
Not really.
Okay.
Let's concentrate on this one because with a neurological pain, usually he's a stiff, you know. So really movements sometimes matters, you know, because he feels stiff, you know, because he sit his leg. The more they walk, they are like stiff, and slowly they ease up. The verse, you know.
So it comes with standing most. Yeah, neurogenic with standing is more. Yeah. Okay. Positive shopping cart sign. This goes with neurogenic.
You know what this sign? What is that?
The cart sign or the tray sign, they call it shopping sign.
Yeah,
it's just to relieve the compression over the vertebral disc.
Correct. So what happened is that they tell you, like you ask him, if you go shopping and use shopping cart, do you walk better? If he said yes, it's a sign of neurological, because when he used a shopping cart, he put his weight on the cart, so he take weight from his spine, so he'll be able to walk further. So if he tell you that I can walk better when I go shopping using shopping cart, this is a sign of neurological symptoms. Correct. Next.
Yeah. Most symptoms located above the knee. This is doesn't go with the vascular, because vascular definitely will come more distal.
Correct. So neuro is more above the knee. Vascular is more distal, like the toes, the feet, you know, cold, numb. So, but the thigh usually goes most with the neurological. Okay, next one.
Symptoms triggered with standing. Also, this one goes with neurogenic.
Correct. And next, last one.
Pain relief with sitting or positional changes. This is also goes with neurogenic. So the best option is A, as you mentioned. Pain relief with cessation of ambulation.
You got the easy question today. Let's get you to that. This is all easy. Let's go to the last question. 13.
I'm always lucky, yes. Okay, thank you. We'll continue. 62 years old woman presents with right thigh cramping after ambulating 250 yards. It resolves after 3 minutes of rest. She has hypertension, a 40-pack years smoking history, and prior left knee replacement of for osteoarthritis. Physical examination reveals palpable pedal pulses bilaterally. The ankle breaker index is 0.89 and 0.9 on the right and left, respectively. The most likely diagnosis, يعني, this
Well,
is, yeah.
let's start before you jump to conclude. Let's go first, okay? She has a pain after walking, relief after 3 minutes of rest, okay? So what is that what?
It could be like claudication because she has the risk factors, hypertension and smoking.
Okay.
And it comes with ambulation, not with standing. It goes with vascular.
So
but the findings, ankle breaker index goes with peripheral vascular disease, mild, yani it's almost normal.
Correct. So what do you think? What do you do in this situation? So her symptom vascular, your workup is normal. So what do you do in this situation?
We do the segmental pressure, toe pressure.
I mean,
or the stress test.
Oh, good. The last one. What you said?
Stress test, just to ask the patient to move, then to measure the ankle breaker index.
That's correct. So when you have like this scenario where you think that patient has a symptom, vascular, and the lab is normal, remember always the lab done in the resting, okay? And if you have like stenosis, it may not show up on the resting, So you have patient on treadmill to reveal it, So what you do is to patient on treadmill. And when she has a symptom, then you measure the ABI. Then you see a significant drop in the ABI. Okay. This is the best way to tell if patient, she has vascular, because the symptoms go with the vascular. Lab is not helping you, but always, as I said, remember, lab is a static. You need something more functional, and the only way you put patient on treadmill and get functional ABI. Okay.
Yes.
So what's like a diagnosis? Let's go with that. Let's go.
Spinal stenosis, it comes with severe pain, all over the radiating pain. This is not the typical picture of spinal stenosis.
Correct, because looks like next.
Yeah, high-grade stenosis of the right iliofemoral and femoral popliteal segments. I don't think, because if this is correct, the ABI will be much less.
What else? She has a pulses, correct?
And palpable, and the pulses will not be palpable. Yes, definitely.
I mean, can you have like a vascular stenosis and palpable pulses?
It's unlikely, but if there is good collaterals, there might be good signals, but palpable pulses.
Okay, let me ask you a question. Very important. When you do like like if you ligate the artery, who should have more? Like if you ligate the subclavian, or if you ligate the brachial, where do you get more ischemia to the hand? See my question? If you go and ligate the subclavian artery, and the second patient you go ligate brachial artery, which one you have more ischemia to the hand? If you ligate the brachial or subclavian artery?
If you ligate, the brachial, it can be ligated in emergency, but which one?
Which one you're going to see patients who can suffer more from ischemia? If you ligate the artery peripherally, or if you ligate it proximally? Or just let's do it from your experience. When you see a patient come with subclavian occlusion and patient come with a brachial artery occlusion, which one more symptomatic?
The brachial artery.
Yeah, the brachial artery, right?
Yes.
So it comes with embolitis, the brachial artery comes with a cold arm. Patient
Yeah.
comes with artery occlusion, sometimes they are asymptomatics, you know. So why I'm telling that, I want to get to the point that the more proximal you ligate the artery will be less effect in the arm, because you still proximal, there's a lot of collaterals, you know. So the same here. If you have a stenosis very proximal, then you may still have a pulses, you know. So that what does that mean is that you can get a pedal pulses, but stenosis has to be very proximal. Like you cannot have SFA. If you ligate the SFA, no way you can get a pulse, pedal pulses. If you ligate common femoral artery, no way you get pedal pulses. But if you have a moderate stenosis in the common iliac, which is very proximal, you can still have a good pulse, you know. And you can see when you do an aortic iliac stenting, sometimes you have stenosis in the iliac. We measure the gradient. We don't see major gradient between right and left. I still have good pulses. So sometimes moderate stenosis in the common iliac, and you still have a good pulse in the femoral and distal. Of course, this is at rest. When he go outside, this pulse will go away, you know. So what I'm trying to say is that the more please guys mute it. Please, Amr. Yeah, it's fine now. Okay, Sam. So this is very important to know. So just reading on the palpable pulses can be 100% accurate. The same for EBI. So symptoms is very important, you know. And so this patient again. So most of the stenosis will be in the common iliac, you know. No way you can have it distal and have a pulses. So let's go one by one. So spinal stenosis, you said wrong. Let's say next one, high-grade stenosis.
Right femoral and femoral popliteal segment, no.
Multi-level disease in the right.
On right, the location of which cannot be determined with this information.
No, when you have multiple level disease, you don't get pulse. You lose a pulse. Again, pulse has to be like only single stenosis, very proximal. You have a pulse. The more you have multiple level, then you're going to lose a pulse. So no one has multiple level patient, you know.
Yeah.
Okay.
Isolated right superficial femoral artery occlusion. No, will not get the pulse. Symptomatic stenosis of the right common iliac artery. If there are good collaterals, yeah, we'll.
So this is the best option. Symptomatic stenosis.
Okay.
Again, it will be like a moderate stenosis. Okay.
Yes.
So this is a good information. So we learn from this question two things. First, palpable pulse doesn't mean it's not a vascular, and second thing, normal lab doesn't mean it's not a vascular because you have to put patient on treadmill. So two message from this question. Okay. So if you have any doubt, put it on treadmill. You know. Sometimes like if you are doing an angiogram and you have a stenosis and you want to decide if it's significant or not, usually we measure the gradient, right?
Yes.
So this is not accurate also. Why is that? Because when patient doing an angiogram on the table, patient is rested, you know. So when he's rested, you may not see gradient between cross the stenosis. So you see it's not significant. But when patient exercise, this stenosis will be significant. So on before the when you see patient in the clinic, it's very easy to tell by sending him to put him on treadmill. But when patient on the table and you do an angiogram and you see stenosis and you want to decide should I treat or not, and you measure the gradient and gradient is not significant, then you're stuck because you cannot put the patient on treadmill. He's already on the table. So the best way, if you want to do that, what do? You give him vasodilators, you know, like bavarian distally, because this will dilate the artery, and this will, you know, decrease the diastolic, and then you can see, then you measure the gradient. If you see gradient, then you can tell that it's significant or not. So if you give a vasodilator, this will resemble very much the treadmill, because that's what a treadmill does. Treadmill, when you patient on exercise, the systolic goes higher and the diastolic goes down. So then the gradient become bigger. Then you can find out the gradient, and then you can unmask the significance of these lesions. Okay.
Yes. Okay.
All right. Let's release you now. You have enough.
Thank you.
Dr. Rashad, you are with us?
Yeah, I'm with you. I'm sorry, I was a little bit late. I was driving, so I couldn't, you know, the car put you on mute automatically.
I see.
I'm with you now.
All right. I know if you heard this question, it was a bit tricky question. Patient with a normal EBI, but he has a symptomatic, stenosis, So we talk about that you have to patient on treadmill, and get a stress, EBI. And if you want to add anything, or we have also Dr. Ali with us today.
Hi, Samer. Hi, everyone.
Right. If you guys want to add anything, please feel free to add anytime. All right. Let's go to the next question. Who was with us? Osama? You want to take it, Osama?
Hello, Dr. Samer. Yes, I can take this.
Go ahead, please.
A 75-year-old woman present to the clinic with 1 year of worsening pain in both legs with walking. She describes pain that radiates from her buttocks into her calves and feet after 5 minutes of ambulation. She describes relief when she stops walking and rest. On examination, she has a normal pedal pulses bilaterally. The diagnostic test that would best differentiate vasculogenic claudication from pseudo-claudication due to neurogenic source is?
Okay, so it's very similar scenario what we talk about it, She's symptomatic, and when she walk, she get the pain, then get away. But she has normal pedal pulses. Again, you see, it's the same, they put us the same problems.
Yes.
Pulses. So
mostly if she has some symptomatics, the buttocks, the occlusion or the pathology will be proximal.
Correct. So, but how you can figure it out? You can do diagnostic test. What diagnosis test? Let's go one by one.
Yes. Okay. A, bilateral lower extremity arterial duplex.
You think that will help?
Maybe it's not give us a proper idea, I think.
Yeah, because she has bubble pulses, so that means she is the same what we talked before. Most of the EBI will be normal, like same scenario. I mean, you can start that, but if EBI normal is not enough, you have to do something else, So what next?
So, B, ankle-brachial index obtained at rest and following exercise.
What do you think about this one? This is the best option.
I think it can help. It is done both at rest and treadmill.
Yes. That's what you should order. So like this patient, our order EBI at rest and after exercise. If she doesn't have a pedal pulses, or severe claudications, then I just maybe do a normal EBI, arterial duplex. But because she's, normal pedal pulses and her symptom go with vasculogenic claudication, then you need to put her on treadmill. So you need to get an exercise. So if you order just EBI without exercise, they will come normal. This will not help. So you need to order EBI with a treadmill. Okay. What about CT angiogram? Well, let's go CT angiogram. Because CT angiogram.
Yes, and CT angio. If it is in the questions, the best modality, we can consider CT angio, but I think we should go step by step. ABI first, then later we can think about CT angio.
What about MRI, lumbar spine? So because we have to tell, maybe she has a spinal stenosis. So let's go get an MRI. This is an option, okay? Or you can do diagnostic angiogram, pelvic angiogram, and low extremity run off to see where's the lesion. I'll tell you why this all wrong, So this patient, again, go back to the question, okay? She has a pain when she walks. It looks like a vascular, but she has a normal pulses, right? So what that means is that is a good chance that her pain is coming from the vascular, but we need to reveal it. And the only way by putting on the stress, what we said, okay? If you do a CT angiogram, you're going to see the lesion, but how do you know if this lesion is responsible for hair claudication or not? You cannot tell, because you can have stenosis and asymptomatics, correct?
Yes.
one or the CT angiogram without having an exercise, EBI, and I see a stenosis, then how do I know this is causing her symptoms? I mean, because you can see angiogram, stenosis, and patient asymptomatics, and still has symptom from neurological. And the same for MRI. You can do MRI and find spinal stenosis, but how can I tell her symptom from the stenosis, not from the vascular? So also because all these static tests, you see, static tests will not help you in this scenario, And the same for aortogram, pelvic angiogram, all of them, they will show you angiogram, they show you the lesion, but they cannot tell you if this is responsible for his symptom. The only way you tell if her symptom related to the vascular or to the lesion by doing a dynamic test, which is a treadmill, an EBI at rest and following exercise. Okay?
Yes.
Can I talk, Samer?
Please, yeah, please.
Yeah, I'm going to ask a little bit trickier question.
Yes.
Now we have exactly this same patient, but she does not have the pedal pulses. And then you do one of the arterial tests, say you do a CT duplex, for example, and you have an arterial lesion, like, for example, a stenosis or a short occlusion of the SFA, and then you go and do the MRI, and you also have spinal stenosis. So the lady has the two pathologies. She has an arterial lesion and also documented by duplex or CT, and also she has a spinal lesion documented by MRI. Now, how can you differentiate whether her symptoms are caused by the arterial pathology or by the neurologic pathology?
Very good question. Come on. It's not for me, right? For the fellow, right? Or to answer?
Absolutely. It's for, I'm sorry, who was the speaker? Dr. Osama?
Yes, Doctor.
Dr. Osama. So what do you think, Dr. Osama?
He's the first. Maybe we have to think about more, but go ahead, Osama, you can try.
Maybe in such a cases, try some patients will improve with some medications like Lyrica for the neurogenic pain more than the vascular pain. So I think maybe we can start the relief medication as one of the options. The other thing.
No, but the question he asking you, Osama, is that you're in the clinic and you have a situation like that. Patient came with an MRI and he came with a CT angiogram. He has them both in his hand. CT angiogram revealed he has an common iliac artery stenosis or occlusion, and MRI showed spinal stenosis. And patient tell you, okay, what should I do? Are you going to treat his?
I think maybe from the history regarding the claudication pain, it will give us some more idea regarding the pain, if it is relief on our wrist or it is continuous. The other thing.
Okay. Dr. Rashad, you want to comment or?
Yes, I'll give you what I do, and maybe Dr. Samer will comment. Surely I will do something like the ankle brachial test at rest and on exercise and see how much this drops. But also I would ask the patient whether the symptoms, whether he can duplicate the symptoms on prolonged standing. Now with the arterial pathology, you never get claudication without exercise. While with the neurologic, many of those patients can get exactly the same symptoms just on prolonged standing or sometimes on doing some specific movement with the spine, like bending or something. So this question could be telling. I don't know whether Dr. Samer have something better to differentiate which is the pathology that's giving the symptoms.
Yeah, I agree 100%. I mean, this is very common, and it depends, as you said, on physical exam. Really, here now, physical exam is very important, and taking good history. Remember, guys, patient doesn't read a book. He will not give you like symptom you want to hear it. You have to get the information out for the patients. Patient come to you and say, my leg hurt. That's all. He doesn't understand. He doesn't know claudication. Doesn't know what walking and resting pain. He doesn't know numbness. He just tell you my legs hurt. So you have to really dig hard in history and talk to him. And as Dr. Rashad said, you have to examine him neurological, what to trigger his symptom, what kind of symptom, where's the location of the symptoms. The second thing is that you can have them both. People, they can have both problems. You can have an arterial and neuro, So if my exam, I can, because sometimes tell you, okay, when I stand for a long time, I have a pain, but also when I walk, I get like a calf pain. So he can have them both sometimes. So if I have to deal with this patient, have them both, usually I tell them, look, I can fix your circulation, but you not expect to improve 100%. You may improve 20 to 30% because sometimes you cannot tell which one is really giving more symptom than the other one. So it could be a tricky sometimes, you know. But the most important really when you get to this situation is physical exam and good history. And if Dr. Ali want to add anything, Ali? All right. Well, let's go to the next question. Number 15. Who want to take it? Rafat? No. Hello? Maitham, you want to take it, Maitham?
Yes, Dr. Samer.
Can take this question.
Yeah. Question 15. A 21-year-old college gymnast presents with the worsening left calf pain and foot paresthesia after exercise. The physical examination finding that may help diagnosis her pathology is.
Well, what do you think, she? Before we go, what do you think?
Likely this is popliteal entrapment.
Correct. So what's the best way to diagnose it?
Excuse me?
How do you diagnose? Which one you think is the right answer?
So I'll go one by one. Absence of pedal pulses at rest. No. Reproducible pain with deep palpation of the left gastrocnemius muscle. That's also not correct one. Loss of pedal pulses with dorsiflexion or plantar flexion of the foot. This is the one. This is the answer. Varicose vein of the calf and thigh.
No.
I don't know why they put it. Absence of left femoral pulse. No. So the answer is C.
Why they put this one? We said why they put, because sometimes you can, you know, a popliteal vein could be compressed also, and then you can have varicose vein. But this is not diagnostic, you see. I mean, yes, you can have varicose. Doesn't mean if you have varicose vein, you have a, you know. So they want to test to make a diagnosis. So yes, you can find varicose vein. It's not a diagnostic, you know. Femoral pulse nothing to do with that. So the best way is to by dorsiflexion and plantiflexion, right?
Yes.
So let's talk about popliteal entrapment syndrome. You know what's the cause of that syndrome?
The popliteal entrapment?
Yes.
It's the insertion of the gastrocnemius muscle. It has different classification. I mean, different types. So it's like a medial insertion of the head and of the gastrocnemius muscle that will cause compression on the popliteal artery. Correct,
because it goes more lateral, right? Because medial head insertion more lateral can compress popliteal artery, and different types. For that case, for the exam, because they may get you, different type asking the exam. So it's important to to read about it for the exam. How we treat it?
Surgically.
By what approach? Anterior, medial, posterior?
Well, I haven't seen more cases of this one, but last time we treated from posterior approach. We have one case and
yes, always you go posterior.
Yeah.
For that, you just go and cut the muscles. You don't have to do anything to the artery unless if it's damaged the artery, you have thrombosis or aneurysm, then you have to deal with that. But most of the time, just cutting the fibers will be okay. Dr. Rashad, you want to add something?
Yeah, do you have a question about how best to diagnose this? What's the investigation of choice?
They put this one as a diagnostic. It's a good question. Okay, go ahead. Maithan, you know what the best you made your diagnosis, right? So in the clinic, but you need more tests to confirm that. What's the best test?
You mean beside the ultrasound?
Okay.
We can get an MRI.
Okay. What is the body going to order? Which one?
I'm not sure. I might order both ultrasound and MRA to see.
But if you want to order ultrasound, you order, just tell ultrasound, normal ultrasound, you can get back normal.
No, ultrasound with the dorsiflexion and plantar flexion. I mean,
Okay.
with special maneuver. I mean, to elicit the.
So this would no, but
yeah.
What about the anatomical problem? Because you have to fix it. I mean, you know the problem, right? So how going to open? What going to fix? Because they're different type. Which type you're going to deal with it? So how do you know?
So we need to get more image than the ultrasound. Maybe for the soft tissue, for the muscles, we can get also the CT. CT will be also fine.
CT best test for the fibers. I mean, for the muscles.
For the muscles, is the MRI is the best.
Okay. So Rashad, you want to add something?
Yeah, I think he got the right answer. So you ask for a vascular ultrasound with the provocative test, and this will show it very beautifully. And then you ask for MRI, MRA to get the exact anatomy so that you know what you have to do during the operation.
Excellent. Yeah. So you need to get them both. You see, get the right answer. Quite good. Okay, Mason, very good job. All right,
Okay.
let's get the here they put angiogram, but you're not going to do that. I mean, I know why they did that. It's not your diagnostic. As I said, ultrasound and MRI. We don't do an angiogram, you know, to make a diagnosis. What is that here? All right, who's here? Who's else here with us today? Bassam, you want to go back? I don't see much people from Mike.
Yes, no problem. Sure. A 55-year-old male smoker with hypertension and hypercholesteremia presents with left lower extremity claudication after walking for a half mile, which is not lifestyle limiting. His ankle breaker index is 0.7. Assuming successful smoking cessation and adherence to risk factor modification, including antiplatelet and cholesterol-lowering medication, statin, the chance that he will develop increased disability warranting intervention over his lifetime is.
So let's before what they are trying to say is that
a claudicant patient who needs only lifestyle modification and medications. So the percentage of improvement of not responding to the treatment.
Okay, stop, Sam. Stop. Well, let's talk about something different. When patient comes with a claudication, okay? And you see him in the clinic, patient is a claudicant, you tell him, okay, you need to exercise, antiplatelets, you know, and statins, correct? Now the question is that, what percentage, you're going to tell you, or I mean, for your information, what percentage they will improve, what percentage will stay the same, and what percentage will get worse and end with the disability required to interventions?
It's
an important.
The improvement will be more than 50%.
Okay.
And if a patient reach to like a stage of critical limb ischemia, the loss of limb will be around 25%. But with medication, it should be 50% will be he will be improved or more even.
Okay. So what's the percentage will end with a disability with worsening claudication required intervention? Like
in this stage, I will choose 5%.
5%. Okay. Well, let's talk about numbers now. That's okay, you know, but you have to know these numbers. When patient comes with claudications, and this is good for the exam, you know, 50%, this is the nature history of claudications. 50% will say, okay, they don't change, no worse, no better. 25% will improve, and 25% will end with worsening. I'm not saying critical limb ischemia, worsening, you know, symptoms, required intervention, do balloon or angioplasty, okay? The one end with tissue loss and amputation is less than 1 to 5%, you know, but this is when we talk about amputation or tissue loss, you know, but just worsening symptoms, only 25%, okay?
Okay.
So when patient come to you, you can tell him, okay, 50% you can stay the same, 5 will be improved. So really 75% will be the same or improve. Only 25% will require intervention later on. The reason why not warranted to do intervention for everyone with a claudication, because if you do intervention for everyone, then 75% they don't need it, and you do them for no reason, and you may push them to the critical limb ischemia. And this is why we're discussing this case on the case discussion like yesterday, you know. So try to conserve it, because the majority they will do fine, the same or get better. Only few, 25%, they may need intervention, and this 25%, very few will end with a tissue loss or really critical limb ischemia, okay?
So 50,
so your best
25.
is 25%, okay?
Okay.
So Rashad, you want to add something?
Can we take a look at the angiogram?
There's no angiogram here.
Oh, I see. Okay. All right.
Sorry,
Okay.
This is was for this one was for the obliter entrapment syndrome.
Previous case. Oh, okay. No, nothing to add. Thank you.
Yeah, no problems. Okay. So again, so the natural history of claudication is benign. This is the whole idea. So you can take your time and you can treat patient conservatively. You know, where patient with a critical limb ischemia, it's not a benign. The majority they end with amputation. So you have to be an aggressive from the beginning. And this is a huge difference between claudication and critical limb ischemia. All right, let's go to the next one. 17. Ahmed, you want Osama, you want to go back? Let's see. I saw here. Let me see who we have here. Zahra, you are with us, Zahra?
Yes, Dr.
Zahra, let's hear your voice. Let's go to the next question.
Yeah. 72-year-old woman presents with bilateral calf claudication, which is noticed only when she takes long walks. She has successfully quit smoking since her last clinic visit and is on aspirin and statin regimen. She has not experienced any significant symptomatic improvement with 3 months of structured exercise therapy. A CT arteriogram indicates task 8 type lesion in the right side superficial femoral artery, and task B, type B lesion in the left SFA. The most appropriate treatment is. So her symptoms only bilateral calf claudication, chronic limb ischemia, task class A disease should be treated open based on strong evidence. No. Task class B.
Let's go before we go. Let's see what the story, because again, we're not trying to solve that question. We try to get some information from the question. Okay. So this patient can walk, and she go a long distance, right? She talk long walk. So that means claudication mild to moderate, correct?
Yes.
And she did everything. She did exercise. She did aspirin, statin. She's not improving. Task CT angiogram showed SFA and the mild stenosis, task A, and the other SFA, task B. Okay. So what recommendation for task A and B and C and D? Let's talk in general. Take class A. What recommendation? Surgery or endovascular?
Endovascular, type A.
And B and C is controversial, and D usually, correct?
Yes, and D open.
Surgery. B and C.
B and C both controversial. B more with endovascular and C more with open.
Correct. So this is a general guideline, of course, you know. So we have now in our mind. So this patient has task A on right, and task B on the. So what are you going to think to do? What do you think you should do? Like you forget what I gave you. What do you think you should do?
Yeah, as long as she has only a claudication and she is on conservative management, she can walk long. distance, I think we don't need to intervene.
Correct. It's a very good answer. Yes, because she walked for a long time. She's taking medication. She's not getting worse. She's the same, you know. And her lesion is not like major lesion, take A and B. I will leave her alone. If she become disabled, claudication, become like she cannot walk maybe like 100 meters, she becomes severe pain, you know, then we go like the same question before. Then we have to do interventions. But as far as they are the same or getting better, we should not intervene. The only time we intervene when they get worse, which is 25%, okay? And this one is not getting worse. There's no reason for intervention. So all this task A and B, they want just to confuse you. But reality, this patient should not touch her. She's fine. She's still the same. It's not getting worse. We just have to watch her and continue conservative management. In the future, if she's getting worse, then we think about intervention. Okay? So let's go to
that. I'll just make a little comment here, if you don't mind, Dr. Samer. The question is tricky because it says she had supervised exercise for 3 months and she had appropriate treatment for 3 months. And really the recommendation is if you put the patient on 3 months supervised exercise and appropriate treatment and he doesn't improve, there is, it's open for intervention. And also the question is tricky because the lesions are very easy, task A and task B. So it's very tempting to intervene. But one should always remember that the indication for intervention in claudication is life-limiting or lifestyle-limiting claudication. So that's very important. So, so this question actually is tricky, but as you said, we should stick to the indication in claudication, and that is if she can walk long enough, then there is no indication for intervention, even if the intervention seems to be very easy.
100% correct, Dr. Rashad. Yes, you see, as Dr. Rashad mentioned, it's very tricky because when failed medical treatment, you have to treat, but at the same time, you have to be careful that it's not a life-limiting, you know. So if it's not limiting her activity, you should not treat it. So it's a tricky questions, you know. But the most important before you decide what to treat is any indication to treat. So as far as her claudication is not limiting her activity, then there's no indication. Then there's no, doesn't matter what they said after that. So yeah, it's a tricky questions, you know. But always you have to treat the patient, guys. Remember, we don't treat angiogram or CT. Patient walking fine, if it doesn't improve, if she's walking fine, you know, we continue with that. All right, let's go now with the questions.
Okay. A, task class A disease should be treated open based on strong evidence. We say that A is for endovascular. Class B disease should be treated endovascularly based on strong evidence. It's controversial and more with endovascular, so no. Open revascularization is superior for those patients with a 5-year life expectancy based on the basal trial.
We'll go back to that. Go continue.
Okay.
Open
revascularization is indicated due to the presence of limb-threatening ischemia. No, she doesn't have limb-threatening ischemia. She has only chronic. No further intervention is required if she does not feel her lifestyle is significantly limited. E. We'll choose E.
What was this one, right? Okay. So let's talk about basal trial. You know, remember this one or not?
Yeah.
What
yeah,
this trial?
I think. Yeah, it's not for claudicant, I think.
Correct. This is for critical limb ischemia, correct?
Yes. Yes.
What the basal trial said, which is endovascular or surgery is better. What about best CLI? And you have basal too, right?
Yeah.
Yeah, this guy is important when you go to the exam because I'm sure you may have a couple of questions about basal trials because they're major trials, you know, and best CLI trials. You know, the best CLI which came recently showed that we are talking about critical limb ischemia, not claudications. Okay, so the moment you see claudication patient, this doesn't apply. So you don't even have to do this question. This question is wrong by default. Doesn't matter what they said. We talk about claudicant. So basal trial will not apply in this patient. Okay, so basal trial mainly for critical limb ischemia, okay, with a tibial disease or below the knee disease. So basal trial showed that which one, surgery or endovascular? Because the problem we have basal 1, we have 2, and now we have a 3. The 2 now showed endovascular first approach is better than surgery, where best CLI showed the surgery is better if you have a good vein and you have life expectancy more than 2 years. So now what the evidence we have, the best CLI trials tell us that if patient has extensive, fimbopopliteal disease and he has a good vein and life expectancy between 2 to 5 years, then you have to use Savanna's vein is better than endovascular. Well, Basel II trial now showed no, they said endovascular is better as a first choice, especially if patient doesn't have a good vein. Because when patient doesn't have good vein, then your choice between endovascular and Gort's graft, then endovascular is better than Gort's graft. So in general, if you have an extensive disease and you have a good vein, do the vein. If it doesn't have good vein, you're going to use a Gore-Tex? No. Do endovascular is much better than the Gort's graft. This is in general. There's of course, a lot of things you have to read in this study about, amputation-free survival, the male, and all this, it's a huge trials, Dr. Rashad, you want to add something?
Just that it's very important to be aware of the Basel trial for all the final vascular exams.
Yeah, and the best CLI now. So you have to read, guys, about it, because I'm sure you get a lot of questions about it in the exam. All right, so let's go to the next question. 18. When who's here with us? Maitham?
Yes, Dr. Samer.
Do we take the 18?
Yeah, sure. So this is a 58-year-old man presents with the buttock and calf pain with short distance ambulation less than 50 meters. His past medical history includes active tobacco use 1 pack per day, hypercholesteremia, coronary artery disease, myocardial infarction, diabetes mellitus, and hypertension. On examination, he has no palpable femoral pulses. Upon further questioning, he complained of the inability to obtain an erection. The most likely cause of the sexual dysfunction is?
It's an easy question. So what do you think is the problems? Where is his symptoms? He has an impotence and he has no femoral pulses, right? So they said?
Yeah, it's most likely he has aortoiliac occlusion.
So,
yeah.
So we don't have to waste this time. It's an easy question.
Easy, yeah.
You get like an easy question so you can keep, and then you have some question you need to think about it. But this one just straightforward, No femoral pulse. He has a buttock claudications, erections, all go with aortoiliac occlusive disease, correct? The Rich syndrome.
Mm-hmm.
Okay. All right, let's go next question. Don't waste our time with this one. 19. You can take this one also.
Okay. 74-year-old woman with a history of heavy tobacco use and metastatic lung cancer presents with a 2-week history of worsening pain in her right foot. She has had stable exertional calf pain for several years, but recently noted acute pain in the toes of her right foot at night. She has palpable femoral pulses, but only Doppler signals in her pedal vessels. Her foot is erythematous and warm when dependent. The most appropriate next step in management is?
Okay, so I think this patient she has heavy tobacco abuse. She has metastatic lung cancer. 2 weeks history in the right foot. She has stable exertional calf pain for several years, but recently she has an acute pain in the toes.
So she has recent wrist pain.
Right.
So the most appropriate is, and she has only signals in her pedal vessels, and she has the rubber color of ischemia in the front when dependent.
Okay. So what are you going to do with her? Let's, before we go to this one. You did a CT angiogram. She has a tibial disease, She has SFA short disease. Somebody guys noise. Okay. So what do you should we do a surgery or should do an endovascular? We go back again to the vessel trial, you know.
So he said the most appropriate next step in management.
Right. That's what I'm saying. So she has a erythema and warm wind. She has a critical limb ischemia, correct?
Yeah.
I agree
And
on
she's 74. We need to do investigations first.
with the
Like,
investigation. Okay, want to the question? Okay, let's go through the answer. Go ahead.
so choice A, smoking cessation and exercise therapy. That will help if she's for sure smoking cessation is important, but that will help if she's claudicant. Now she has a wrist pain.
Okay.
So pain control and antibiotic. Pain control for sure she needs pain control. Antibiotics she has only a rubber color of ischemia. This is not not infection, the erythematous color that she has.
Okay.
So CTA to evaluate for tibial occlusive disease. This is could be a correct one. Right lower extremity angiography with possible intervention.
Go ahead.
Also another one. Diagnostic right lower extremity angio followed by femoral to below-knee popliteal artery bypass with saphenous vein.
All right.
So I think I will go. If there is a choice for arterial duplex, I will choose for sure. But for CTs, I might go for CTA to evaluate for the tibial occlusive disease. I will not jump to the angiography or more invasive without having a diagnosis. I mean, to know the level of occlusion.
Okay. Well, let's go one by one. Okay. Smoking and cessation and exercise. We said this is wrong because we are out of, claudication. We have to do something. Otherwise, she ends amputation, correct?
Yeah.
So measurement is okay. So now we end with a C and D and E. There is a noise. Where is that? Somebody speaker is open. Maybe Rafat.
It's Maisam. If you just put yourself on mute, Maisam, when you don't talk.
Yeah.
No, it's not me.
Okay. So pain control and CT angiogram to avoid tibial disease, tibial occlusive disease. You think CT angiogram is the best test to evaluate tibial disease?
No.
Because you cannot. So most of the time, you cannot. The worst part for tibial disease is CT angiogram is the worst test for tibial disease.
Yeah, I think Publix is better for tibials.
Right. So this answer. So you end with the D and E. So D tell you that you're going to do an angiogram and post intervention, or you're going to do an angiogram and bypass. Because angiogram is going to show you like maybe SFA, popliteal occlusions. But the whole idea from this question is going to tell you you're going to find the tibial disease or popliteal or SFA, whatever. Are you going to do endovascular first or surgery first? Are you going to go with basal 2 trial or going to a best CLI trial? What do you think should apply on this patient?
For this patient, we'll go with endovascular.
Why not bypass? Best CLI show you bypass is much better than, especially if you have a good vein. Why don't go with a bypass? Because you go back to the question. What's the question tell you?
74. Lung cancer patient, metastatic.
Correct. So life is less than
life expectancy is
less than 2 years.
It's not that long.
Right. So best CLI and vessel trial, you should live at least 2 years. So if you have less than 2 years, it doesn't work to go through a surgery. So this will not apply. It's the reason why in this patient the best way to do endovascular, because life expectancy is short. If it doesn't have a lung cancer, then your best option to go with a FEM distal bypass with a good vein. Okay. So on this one, her answer would be D, correct?
D.
Okay. You want to add something?
Yeah, just one little comment. she has been ischemic for some time, and then she got worse recently. So it's suggestive that this patient may have developed acute thrombosis on top of a chronic lesion. So if one is going to do an intervention, one has to be prepared to do something, you know, to relieve the acute occlusion as well as the chronic occlusion. For example, she might need, you know, some kind of catheter-based thrombectomy or thrombolysis, followed by the appropriate intervention. I mean, one has to keep it in mind, just in case you find acute thrombosis.
Correct. Rafat, you want to you read about, you know, Basel II trial and BCLI.
Sure,
you want to speak for the guys, you know, for the fellows, for the exam.
Sure,
Yes,
sure. So this
Point.
CLI trial is actually we were part of it. It's a very important trial. It's probably one of the most important trials in vascular surgery these days. So it's about 1,600 patients, multiple centers internationally. Like Dr. Samer said, it's what they found is if you have a good non-composite meaning one-piece vein, it's probably the best way to go, even if the patient is endovascularly amenable. So, and that's been proven. And then if you don't have a non-composite vein, then you can do a graft bypass or endovascular, depends on the expertise. They're both good. The Basel II trial, unfortunately, it's a little bit unpowered because the amount of patients there is about 380 patients compared to 1,600. So if you really increase the endo arm, you know, probably they're gonna swing back, you know. So the Basel II trial showed endovascular treatment is better than open vein bypass in the below-knee vessels only. So these are very important trials to find out. But I think the best CLI trial, and there's a lot of studies are coming out from that trial, because you can't, the finding of this study, you can't just put them in one paper, you know. So if the bottom line, like Dr. Samer said, if you have a good vein, one non-composite vein, that's the way to go, and that's what you should do. First line therapy. And then the rest depends on the expertise, depends what you're doing. So this is really the gist of it. And I think there's a collaboration between the two trials. There's some studies coming out to figure out what to reconcile the differences, you know, but the best CLI trial is a very, very good trial, and I think it should be followed. It's much more power, has more power than the CLI trial. So I'm gonna go back to this. Go ahead, Dr. Samer.
Go ahead, finish. Sorry, go ahead.
I'll go back to this question. So in this question, they're telling you, just for American questions at least, you know, they're telling you the patient has palpable femoral pulse. Automatically, they want you to do angiogram, because they won't say that, you know, normally. So, and it's not wrong, you know, if somebody has a palpable femoral pulse to do diagnostic angiogram, that's not wrong at all. So in fact, we do ultrasound, and we don't hardly do any CTAs, you know, in general, or MRAs, or even, so it's not wrong to do diagnostic angiogram if you have a +2 pulse in general. And in terms of thrombolysis, this question, you know, may be tricky because the patient has metastatic lung cancer, so that relative contraindication with thrombolysis. But you have to be careful also, like Dr. Bashar said, that Rashad said that's you know, it could be acute and chronic, you know. But I think, you know, the point that I'm trying to make, if it is palpable femoral pulse, it's okay to do angiogram right away. So
I agree with that. And again, I mean, we go to this history. I mean, the answer they put is wrong. I mean, as you said, if like this patient, 2 weeks history of sudden pain, most of it, she has a cancer, most of it, she's emboli. What I will do, I do an angiogram and do thrombolysis. This is what most probably I will do, you know, but it's not one of this option here. But most of it is the best what you do for this patient. But if you have to pick up one of these answers, I think the intervention is the best one. But Rafat, let me give you scenarios for the fellows to you know, for the future for them. So you have patient with again, let's say popliteal occlusions, you know, and critical limb ischemia, and of course, you know, PCLI said you have do fem distal bypass, and a good vein. You don't have a vein. So now options. Let me give you the option, and you can tell what's the best, or what your algorithm, how you pick up with the next step if you don't have a good vein. Next is to go to the contralateral saphenous vein. femdistal below the knee using, heparin bounding graft, endovascular, or sliced vein from the legs or the arm. What algorithm you put for the fellow to fellow? What do you think they should be next option, third, fourth option?
So my approach with this is it depends on what kind of target you have and how amenable endo. Endo is not bad because remember, if you have a wound and you're doing tibial work, which really you should be doing tibial work only for a critical ischemia only. So if you have a good target, you can consider bypass. But I always do endo first because all what you need just to have that patient heal. And you may need, the vessels be open for 3-4 months. You can maintain that. And if they heal, it doesn't matter if they're open or not anymore. But when you talk about bypass, it really becomes important. Two things. Number one is the target vessel. Is it calcified? Is it bad? Is it meniscus? And then the outflow. How the outflow on the foot. Is the arch intact? Is not intact? So these are important for when you consider bypass. If you talk to Dr. Veith, he tells you to do a graft is okay to do a graft for these for tibial bypasses. Which is, I have a partner that does a lot of tibial bypasses with graft and they stay open. But the key is the target there, But I think my algorithm is to do endo first if I can, and I'd go from above, from below. And if that doesn't work, then we can consider bypass if there's a good target. If there's no good target, then we can do limb flow. I don't do limb flow, but one of my partners does them, or do something in that nature, to try to save the leg. So.
Okay, Dr. Rashad, what do you think? What's your algorithm?
Well, I'll get the high quality duplex first because this gives a lot of information. It will give information about the amount of acute thrombus there is or acute embolus, and also to give information about the grade saphenous on the ipsilateral side and contralateral side. And also we depend on the duplex to assess the target vessels, whether we have a good target vessel for bypass or not. And then we put all this together. Now, most likely, with a patient that's 74-year-old with a cancer lung, which is metastatic and a short life expectancy, I would tend to do endovascular. So if there is a contraindication for lytic therapy, I would go with some kind of mechanical thrombectomy, percutaneous mechanical thrombectomy, maybe use a little lytic therapy and then angioplasty. Now, unless the patient is really in good shape and she's fit and endovascular is unlikely to work, she has a good grade saphenous and she has a good target vessel, and then I would do a bypass. But most likely in a patient like this, I would be tending to use endovascular solutions first.
Okay, thank you, Dr. Rashad. So, okay, guys, so just to summarize it now. So again, if you have like an extensive femoral popliteal disease and you have to go below the knee, your first option, the best option is to do it with a good vein. If he has a good vein, to go with a femdistal bypass. This is what best CLI trial tell us. If you don't have good vein, this is a question. Should you go to use a Gore-Tex or should you jump to the arm and take the arm vein? I don't think there are good options. I prefer to then next step to do an endovascular. Better than going to the arm and take a vein from the arm or slice a couple vein and put them together, because studies show that sliced vein, they don't work very well like a good single vein, And Gore-Tex graft is not good, especially if you have critical ischemia and you have a wound infection, you may get infected. The patency is not great. So I think my next step will do endovascular. I will not do graft or slice vein unless in extreme situations, So I think this is what most of us, we agree on that. All right, let's go to the last question. We're running late. But Sam, you want to take it, Sam?
Yes.
Let's go. Hopefully be easy one. 20, where's 20? This is a 20. Okay, go ahead.
A 73-year-old man with a history of diabetes and renal insufficiency has non-healing wounds of the left foot. The skin of the foot is atrophic with rubber, and there are gangrenous wounds of the first and second digits. He has palpable femoral pulses, but no palpable pulses distally on either limb. Non-invasive arterial testing reveals a left leg ankle breaker index of 1.4 with moderate to severe blunting of pulse volume, recordings at the calf and the ankle. Toe pressure index is 15 millimeter. The most likely diagnosis is.
So
Okay,
what
this is okay.
sorry?
1.4 ABI is false positive.
Why is that?
Can you hear me, Dr. Samer?
Yes, I can hear you. Why is false positive? What does that mean?
Because of heavy calcification, it's very high, so we don't take it. We don't consider it. We take the toe pressure index,
which is low here. Okay.
But this patient is an elderly with critical limb ischemia, maybe with some infection also.
Okay, what does it? Go ahead. Quick.
So the most likely diagnosis is normal arterial perfusion with neuropathic ulcers. No, this is wrong. Microembolic occlusion of digital vessels. With toe pressure index, no, I will not. Yeah, it's not correct. Acute ischemia from popliteal artery thrombosis, no. Chronic limb threatening ischemia with calcific arteriopathy, yes, I will take this one. Severe small vessel arteriopathy affecting digital vessels. No, the correct answer is D.
Yeah, because you have a pulses. You don't have no pulses. If you have a small vessel disease, then you have a pulses. He said no pulses, so no pulses distally. Okay, so we're thinking about medium-sized artery occlusions. So we're not talking about small vessel disease. So I think yes, currently ischemia with classification because of the ABI is high. I think it's just straightforward question. I think it's been like 1 hour now. I think it's enough for you guys. And happy holiday for the whole Saudi guys, fellows here with us. Anything you want to add, Rafat? Nothing. All right. So again, you had enough, right? Or want to continue, guys?
No, it's okay. Yeah, we are enjoying our time with you, Dr. Samer, and the expert people, mashallah, Dr. Rafat and Dr. Rashid.
Let's take one more question, okay? Because this question was stupid. Let's go one more question. Are we done? Okay, go ahead.
Okay.
Go ahead, Sam. You suggest to continue. Go ahead.
Yeah, 70. Okay, thank you. A 78 years old woman with a history of coronary artery disease, congestive heart failure, and smoking presents with a non-healing ulcer of the left second toe and ankle brachial index of 0.3 on the affected side. She is currently taking atenolol and furosemide. In addition to discussing revascularization to prevent limb loss, medical management includes.
So what do we give her?
Yeah, usually we give, with revascularization, we give aspirin and Plavix, dual antiplatelet with statin. Yeah, she's on, yeah. So A, aspirin 81 daily. Okay. B, aspirin and atorvastatin 40. C, 81 aspirin, atorvastatin, and metoprolol. D, aspirin daily and atorvastatin 80. Okay, so E, aspirin plus metoprolol plus clopidogrel.
Well, I tell you,
okay.
It looks difficult, but it's really easy. Let's start one by one. Metoprolol, do we give it or not? Do we need to give it? Beta blocker.
Usually we don't give, yeah.
I mean,
unless there is a problem with the heart.
No, but there was some studies before showed that beta blocker can improve. Patient give it to the Vascular, but the study was very weak, and we stopped doing that. But it came at some period, beta blocker. We thought this will improve, for patients with vascular disease. But again, all strong studies doesn't work, so we stopped doing that. So metoprolol is out of question. Okay, so this will take E. The equation will take C from out of question. So we end. Aspirin alone, I don't think is enough. You have to give him also statin, right?
Statin.
Azole, so only with B and D, right?
Yes.
So,
so yeah, for coronary, they advise for 80 atorvastatin with the aspirin.
Correct. So the right answer would be D. Correct?
Yeah.
You see,
okay.
It looks confusing, but when you think about it, take off one thing, use it to become easier when so yes, they advise to give 80 milligram, atorvastatin and give 81 aspirin. Like adding blood, we do that, but no study really showed that dual antiplatelet is better than single. For the vascular disease, for coronary, yes, but for vascular, we don't do that. We just, we follow up what the cardiology do. We give them both, but reality, single is enough, especially with the statin. Rafat, you want to add something, or Dr. Rashad? And this will be our final question.
Yeah, I just want to make the point that there are studies which showed that statin improves mortality outcomes in patients undergoing peripheral bypass. So we always give statin to patients before doing a peripheral bypass, in addition to aspirin, of course.
Yeah. What about beta blocker, metoprolol?
No, we stopped doing this.
Yeah, we stopped doing that. Yeah. All right, guys. Thank you very much, and we stay a bit late, and we'll see you next week. Take care. Thank you, Rafat, and thank you, Dr. Rashad.
Yeah, no problem.
Thank you.
Thank you.
Take care.